So in any event, you've been listening to science and data and looking at tables and listening to experts talk about the different variations on treatment. But for this hour, you're going to hear something different because each one of us who for you right now has lived through was really a nightmare of addiction in the family. A loved one, whether it's a child or a brother, someone in our family uh, had addiction, and we had to make it through and face the reality of what it's like to find treatment, and then ultimately faced the deepest nightmare that we live with every day. And each of us knows, I know that these deaths were preventable had we only known what to do at that time. Now I have a better idea, but back then I sure did not. And each one of us has a similar story that parallel, but there's a difference to each one that I hope that you'll learn something from. And from my perspective, I'd like you to leave this hour or finish this hour having picked up something that perhaps you didn't know, and something that will help you to prevent what is really the ultimate tragedy. Something that I'm a hospice physician, and so I'm around death every day. I'm around death 20 times a week, and I thought, oh, I'm ready for it. And I'm an emergency physician. I've been around, I don't know, a couple of thousand sudden deaths, and I thought, I'm ready for it. But no, I found out the hard way I'm not. So that's what you're working for. And so about me, I want you to know that in all my years of education and my residency and my fellowship here in Boston and my MPH in epidemiology in Baltimore, I never had a single day or a single hour of education about the treatment of addiction. I did not know that it is a treatable disorder. I did not. I didn't seek it out on my own, and it was never offered to me. And when my son, Mackie, Dan, if you can put that up, became addicted, I didn't even know it for the first year of his addiction. That's him in the light suit, together with his brother and best friend, who goes by Dan, except to me, he goes by Homie his entire life. And so not only were they tight brothers, they were best friends. So Homie goes through the rest of his life with a hole in his heart. And he also feels responsible for what happened, just like I do. And but I really did not recognize, and I also didn't believe that in the genetic predisposition. I just thought it's not true. I thought that's hair color and eye color and sickle cell anemia. And later on, I learned about the truth of that. Mackie was a very soft-spoken, very gentle, warm, bookish young man who had a tremendous genetic predisposition and just a crush of adverse childhood experiences, which I didn't see happening, even though most of those came from me. He became addicted after he started using pills, found peace in that feeling, discovered heroin, found real peace with that for a while. And I just didn't even know about it until eventually I found out, and I became furious with him. I thought it was a choice every single time he picked up a needle. I was in his face. I was furious about it. I eventually locked him out and threw him out of the house. And he found treatment on his own with Suboxone. But I was not involved in that treatment. I was never contacted by the doctor. I was never spoken with. I was never involved in group. And I knew nothing about it except I had to write a check or hand him green money or the doctor wouldn't see him. And then it was yours truly who forced Mackie to stop the Suboxone. As soon as he was sober and he was looking like that, I said, Mackie, get off of that stuff. You don't need to be on any drugs. And I made him stop. So he stopped, and he wasn't in withdrawal, but he was naked to the world if he were ever exposed to opioids again. That's what I did. And along the way, I delivered snippets of "I love you, Mackie," and I go up in his room and stroke his hair and tell him how much I care about him and I want the best for him, and left him, hey, which is it? Do you love me or do you hate me? And now I know how I should have acted, but at that time, I think that's what families do. I know that's what I did. And I want you to know what happens in real life, what did happen in real life when we sought out treatment, because it was pretty awful. When we went to the ER, there were several times he said, "Okay, Dad, I'll agree to treatment." We went to the ER, and they knew I was an emergency physician, and usually they're kind of nice to you that way. But his chart went to the bottom rack. I kept seeing it being moved down and moved down and moved down, and we were there all day. And then we were there till about 3 o'clock in the morning. Doctor saw him for about 3 minutes, and then off we went to a rehab center. And I had in my mind a rehab center, a clean place with clinicians who care. And oh my God, we're on the right track. And we arrived at what looked like an abandoned home. The place was in the basement. There was mold on the stairs and a big creaky iron door like in a movie. And then I walked out of there, leaving him there at 17 with a big clang of that door. And I just couldn't do it. I went and took him out of there. And that's my one and only experience with rehab. I hope it's better now. He agreed to go to detox. So I see the billboards and I hear the ads and no detox, detox, detox. So we went there, and they took his insurance card. They didn't ask about his health questions. They didn't ask me about his health. They took his insurance card and they were gone for about an hour and came back and said, "We can't help him." And so they sent us away. And they said, "If he gets sick, bring him back. We'll keep him for 3 days." I went to my own doctor. They said, "There's no, well, it's hard to say these things, but it's true." I said, "Is there anyone here who can help my son recover from addiction?" And the doctor laughed and said, "We're way too busy for that." And then he sent flowers to the funeral. I asked another doctor, "Can you help, please?" And he looked me right in the eye and he said, "I don't want those people in my office." It's my son he was talking about. Another one said, "There's no money in it. I'm not going to do it." And another one said, another doctor asked me, "Is everything else going well in your life, Jim, after physical and the whole exam?" "Well, except for my son, who I'm afraid is going to die from an overdose. And I don't know what to do. It's tearing me apart." "Well, I hope he finds help," and essentially ran out the door of the office. So I saw Mackie. He was looking like this in the last months of his life on Christmas morning. And the last, I have tissues. So you understand. So I said, "I love you, Mackie." And he said, "I love you, Dad." And the next time I saw him was in a coffin. So what can we do? What can we do as an organization? What can you do as clinicians? What can families do? And from my perspective, the most important thing you can do is to be kind to the patients. And if you're a family, to be understanding that it's not a choice. It really is a disorder. And then when you're ready, when you can take a deep breath and step forward and raise your voice and speak up, is to be an advocate for change. And I did that as best I could, and I'm still doing it the best I can. And when I'm your president, I intend to do even more of that, because change is what we need. I don't know how many of you know about the MODA Act, but modernizing methadone treatment. Industry fought back against that and was removed. But we need to fight hard and make methadone available. And we need to fight hard for MASAM. And we need to fight hard for housing. There's a whole lot we can do working together. We have powerful voices, we as a group and us as an organization. And with that, let me thank you for listening and ask Dan to present his story.
Morning. My name is Dan Harper, and I really appreciate the opportunity to be part of this conversation. Very important conversation, very emotional conversation. For you? Is that any better? Okay. This is a picture of my daughter, Eliza. Geez, this is emotional, isn't it? She's my second born out of 5 kids. She is hot ticket, smart kid, fun kid, beautiful kid, imaginative, above all, compassionate. She was a good friend to all of her friends. And there was an expression, she never knew any strangers. And that kind of describes Eliza. And I think it's important for us, for you to see Eliza, for you to see Mackie, for you to see all our loved ones as Eliza, right? Let's not wrap the stigma of addiction around her. Let's not label her with this. Let's look at her as a person first. Thank you. Holy smokes, we got a big stack. Jim asked me to share a couple point of what would be important to tell you folks of what we lived through during Liza's battle with addiction. And I'm going to try and squeeze in a couple of points. The first, I also want to tell you, other than Eliza being a wonderful, wonderful person, there is kind of this OUD part that I need to kind of fully flesh out. She was diagnosed with PTSD, depression, anxiety, and substance use disorder. Right, so let's just try and put those in 2 different boxes for the moment. The biggest problem that we ran into that I can share with you is continuity of care. I'm a systems guy. I've been writing code for 20 years. I look at things from the 5-mile out view. And when we discovered that Eliza had heroin addiction, it was ridiculously disruptive. My world was upside down. I was operating in this bubble of stigma. I didn't know who to reach out to, but I thought, hey, I got an insurance card in my back pocket, and I know the medical world is going to help me out. So we called up our primary care and said, hey, guess what? We got a problem. Eliza's got addiction. How do we deal with this? Our primary care said to us, you know, that's not really my area. Why don't we send her over to Clean Slate? Okay, so we go over to Clean Slate and we get on Suboxone. We get on drug screening. She gets a therapist. She gets some. I don't think she got a doc. I think she got a social worker. But you know, drug tests, things are going okay. She's also working. She missed an appointment, got kicked out of that program. What do we do now? Oh, let's go over to, what was the other one? CSO, clinical support option. We were there for a little bit. And Vivitrol, I think, was the treatment of choice there. So, okay, so here I am dealing with, okay, my daughter's in trouble. How do I help her? We got Suboxone, didn't work. This doctor, that doctor, this therapy. She overdosed and relapsed and overdosed while she was there. And so we sent her then to a treatment facility in Eastern Massachusetts. And so this is where like, the insurance company comes in, right? I got the card, just swipe it. That's great. She's in a place, she's safe. I know she's gonna be all right. But come to find out at the end of 2 weeks, her treatment is done. And she's back home. And what are we left to do? 2 weeks is not enough, right? And I think we all know the story. She reused, relapsed, overdosed. But where do we go? The insurance is used up in Massachusetts. So we send her to Vermont. She gets a new doc in Vermont. That insurance gets used up. She comes home. Where do we send her? Florida. Why not? Right? This is my daughter. This is my flesh and blood that I want to protect. And I'm sending her all over the nation for help. California was the one place where she ended up getting the most help because of insurance. But here's the thing. She went through a bunch of doctors. She went through a bunch of treatment plans, all in separate buckets, all in isolation. Not one doctor talked to another doctor, not one diagnosis was shared. And meanwhile, I'm still the dad trying to figure out, where's my daughter in all of this? I want to connect with her. I want to help her. And I don't know what layer of medication is going through her system, what she's coming off of, what she's going on. Is she reusing? I don't know. All of this story kind of just boils down to this. I was looking for help and I got nothing but confusion. And I'll just kind of leave that there. It feels to me like a very broken system. And again, I'm a systems guy. I got to think that somehow these records can follow people and that record from Dr. A and notes can go to Dr. B. I'm going to try and squeeze 2 of these things in. I said that I was a programmer. I fix things with code. I said that I was a father of 5. I fix things when kids are hurting. My Eliza's world just came back to this one moment on the couch in her family home when her breathing stopped because there was fentanyl in the heroin that she was using. What was missing from that moment in her day was the ability to call out for help. My youngest daughter was upstairs sleeping. We had fentanyl in the kitchen drawer. We all knew how to use it. Did I say fentanyl? I felt like I was doing really well up until that point. I hope we didn't have fentanyl. The point is that she couldn't call for help, right? So I invented, because that's what I do, a thing called Eliza's watch. And it goes on her wrist and she wears it all day long. And if she finds herself using alone, which over 50% of the overdoses are from people using unobserved, it's going to sound an alarm and it's going to wake up my daughter upstairs and she's going to grab the fentanyl. Damn it. Narcan. I'm just going to stop on that word and have you fill in. Keep on distracting myself on this. So that's the plan for Eliza's watch. It's an idea. I have a team of docs working with me on this thing. We're gonna pass this thing out. We're gonna build this thing for under $10 each. It should be at clean needle exchanges. It should be at Narcan distribution. Anybody in the state of Massachusetts is going to have one of these things on their wrist within 2 years if they want it. Because people don't want to die. It's that simple. People need health. They need options. They need harm reduction. And this is just one teeny tiny little idea against this multifaceted monster of a problem And I'm getting close to burning up my 10 minutes, so I'm gonna stop it there. I'm gonna say, thinking outside the box, it's a brilliant idea. And I'm also gonna say the continuity of care, that's a big 5 mile out problem, but we gotta look at that. I appreciate your listening and I appreciate your time. This is my good friend Julian.
My good friend Dan. And I just want to say, I'm so sorry for your loss. My name is Joanne Peterson, and I'm a mom of a son in recovery. I'm a sister of a brother who passed away in 2011. I'm an aunt of a niece that passed away of a fentanyl overdose in July of 2018. And then we just buried her son's father, and I placed his flag along with hers right there on Boston Common a couple weeks ago. So my nephew is now parentless. I could talk a lot about Learn to Cope, but I think I'm here today as just Joanne, mother, sister, aunt, great aunt, and family that's trying to help an 18-year-old boy get to UMass, who's currently on a medical leave because his father just died. And UMass has been great about granting him not to have to go until next semester, but I'm not sure that will happen. So I'm just Joanne, friend of many. I see some even in this room from over the last 20 years of running Learn to Cope. But really Learn to Cope started when I was about 10 years old, when my brother was incarcerated over and over and over for his substance use disorder. But back then we used to just say he was crazy, or he drank too much, or he can't stop using drugs. How come? But the police would come banging on the door because of petty crime and drag him out and throw him back in jail. And he actually did more time than someone that probably murdered somebody. And he finally died in 2011 at Safe Harbor, which treated him with compassion and care, I might add, out on Long Island in Quincy. And also the Shattuck was the one place where I finally saw compassion for him. He had HIV, and he was very ashamed. We're all stigmatized from the time I was a little girl until 2001, when my son became addicted to prescription pills and turned to heroin, and we started getting stigmatized in my adult life. And I said, no, that's not happening. I'm not going through this for the rest of my life. I'm not going to allow anyone to stigmatize my family or my other children or my son, and I'm going to get him help. But then, as Dan described, it wasn't as easy as people might have thought. Back in those days, there were no beds, really. There were all sorts of budget cuts, and there were, people were dying then. He was one of 5 kids that had gone to a home where the father was sharing his OxyContin prescriptions with his son and my son and 4 other boys. And only 2 of them are alive today. That's my son and one of the others. We didn't have a lot of education back then. I reached out for help and I raised my hand at a meeting and I was told, stop right there. This meeting is not about you. It's not about your son. It's about you. And I said, no, he's 18. He's going to die. I don't know what to do. Where do I go? I need resources. Well, we don't do that here. So I got up and I walked out and I just came out. My son at that point was incarcerated, just like my brother had been. So I was traumatized, stigmatized. I was full of shame. I was blaming myself. And I just wanted to help my son. And my mother, who was my hero, went all those years with my brother without any help because of shame and stigma and being looked at as, well, what kind of parent were you? Or, instead of looking at the condition that our family members have, sometimes in ways that they can help them, it's more about, well, why can't you just stop this? Or like what we heard earlier, why are you doing this? You have wounds. I mean, the understanding today, I do have to say, gives me so much more hope than I ever had in my life with this, because I've lived around addiction and mental health conditions in my family since I was a little girl. My sister is 62 in a nursing home because of alcohol and schizophrenia, where years ago in the 70s, she walked around town with rosary beads around her neck and bare feet, and everyone said she was crazy. And then with my brother's conditions, well, he's just an alcoholic, arrest him, put him back in jail. So I guess what I'm saying is, when you talk about generational trauma and genes, it's in my genes. I don't know how I'm okay, and maybe I'm not. I might not be at times. But if you want to learn more about Learn to Cope, you can go to our website, learn with the number 2cope.org, and you can see all of what we do there. And part of it in meeting people like Dan and others, they have saved me, which has, one thing I can tell you too, is education and compassion for a family member is key. I have sat in emergency rooms and jails for years and been put in the corner and, treated like crap, excuse my language, and at the bottom of the list. And, you're just, if you don't want to get clean, then just get out. Things like that. If you see a mother or a father sitting on that gurney with their son or daughter or spouse or niece or nephew, a glass of water, Kleenex, a hand on the shoulder saying, is there anything I can do for you? Or here's a couple of phone numbers. There's Al-Anon, there's Learn to Cope, there's parents supporting parents. There's all sorts of things out there that you can tell a family member about, or just hand them a packet that's a little bit of education on addiction, substance use disorder. Words hurt. Words are very stigmatizing. Anyway, I'm going to wrap because I think that's my 10 minutes too. And I'm just grateful to be here and to be listened to be heard. Family needs to be heard. And we are not bad parents. We love our kids. One more thing. My husband's a diabetic. When he got really sick, our entire family was educated on how to recognize hypo or hyperglycemia. We were shown how to use a needle for insulin with an orange. With this, out, get out. And I'm not saying all of you do that. But we get treated like animals sometimes, and bad parents and bad parents. So I'm going to end with that. And again, thank you so much.
Hello. Gonna jump right to it. Here's Casey's story. I will tell it a little differently. I ask you to stay with me as I share her memory. On June 12th, 2023, Savannah lost her mommy. How do we tell a 5-year-old that tomorrow will dawn when mommy is gone? We sat at the living room just like any other day, trying to find a way. Coming together, we were able to tell her. Here's what we said. Mommy went to heaven, so you won't see her tomorrow. We could see she was trying to make sense of what we meant. But how could she, when even we were out of touch with this new reality? With her little brown eyes, Savannah scanned the room, perhaps waiting for more information. As silence filled the air, all she could say was, okay. She stood up and went to play. It was a paper airplane game Savannah and her uncle played that day. Suddenly she came running hysterically. Her voice trembled and her tears filled her eyes as she tried desperately to get her words out. She finally was able to muster a sentence with a stutter. My airplane won't stay up in the sky to heaven. I made mommy a picture and I can't send it to her. Casey was only 21 years old when she lost her life to opiate overdose. But overdose was not the primary culprit. Her untreated mental health disorder journey paved the tragic path that led her to her death. I remember our little Casey, full of life and wonder, always in a rush, for she had places to go, people to see, riding her tricycle or playing with her Barbie. Her adventures were filled with marvels and endless possibilities. Dressing up at every opportunity, she could become anyone she wanted to be. Her favorite place was always with family. Does she feel familiar? We all have a Casey in our family. I bet you can picture them right now, living so carefree. What if you couldn't protect them from this harsh reality? What would you do if you lost your Casey? Maybe you have lost your Casey. Now let me tell you her story. We witnessed the inner light fading, darkness seemed to slowly sneak up on her, eventually enveloping her in her own darkness of pain. Despite our cries, we were met with sighs. Doors were shut, excuses were given, and we were put to shame by being given false blame. We witnessed the spread of societal biases within the health profession, systems plagued with infections, of preconceived notions about age and how girls should behave. From the mouth of those who took an oath to care for us, we were lashed with society's gender stereotype. Girls are emotional, they always complain, they just want the hype. Ignoring the very fact that attention-seeking behavior is a manifestation of deep human need. However, it's often perceived as something low, a manipulative illusion, much like an act of collusion. When her struggles became too burdensome for society, suddenly the narrative changed. School raised concerns, reports were filed, and courts became involved. Her inner pain transformed into a prickly thorn in the side of societal institutions. Now they're open to discussing her situation. Finally, we had some confirmation. PTSD, bipolar, ADHD, and anxiety. We thought our answers would make it easy. However, now she faced even more scrutiny. Before she was a troubled teen, now she was a victim, sometimes as acting. How can this be? If someone is diagnosed with a physical condition, they're not blamed for their affliction. So why is mental health considered a figment of our imagination? We tried to protect her every day, in every way we could, but these systems didn't see her as they should. Society's narrative about mental health promotes shame and negativity, creating a self-fulfilling prophecy. It is important to understand that what mental health can do, but is the story told over and over that pushes the soul down deeper and deeper. Can you imagine how a child would feel when looking up their diagnosis? It is hard for them to see a way out and feel empowered when all they see is a negative stigma attached to what is now their name, their new identity. Medications were prescribed, but when it came to therapy, well, that was entirely a different story. It was as if they said, here's your meds, now sort it out. Support seemed to be either neglected or treated as a rare commodity. Numerous obstacles stood in her way. Therapy appointments were a distant dream. How could she access therapy when therapy itself seemed in need of healing? The scarcity of counseling services, overwhelmed by the demands of a growing population, only compound the challenge. Lots of these diseases, these dual diagnoses embedded in the stigma of systemic inequity. Systemic inequity has intersectionality. It's not just about color, you see. It's about age, gender, and even femininity, as it's defined by society. Even Casey faced systematic inequities, not due to her color of skin, but several intersectionalities, the gender she lived in, the age she carried, and her family's history. As I sit here taking you through Casey's journey, mental health journey, it all leads to the moment, the day when all that had to be done to protect her, to support her, was taken away. We didn't fail Casey. The systems and policies did. DCF made their choices. The courts took her away. And the Rogers hearing meant to protect her became the real neglect. Substituting anxiety meds she needed, pot was given to her by the very guardian that we knew should have never been made. But family, our voices, are often silenced for the supposed protection of the people we love. There's no balance. It's all or nothing, or gray areas allow for pruning of special populations. No longer receiving her life-saving medication, she went out to find her own solutions, turning to triple C, heroin, cocaine, benzodiazepines, and fentanyl. After losing Savannah's custody, Casey did the best she could to get back to where she should, receiving MOUD from some of these very facilities. However, only meeting with psychiatry, still no therapy. Her mental health was invisible. She was left with no dual treatment or sufficient support. Still, Casey was able to maintain bursts of sobriety to be able to see her baby. Casey continued on and off the Green Mile, in and out of hospitals. Narcan could only save her so many times. In one instance, she had to be Narcan 7 times, yet she still was released from the hospital 5 hours later. There are so many gaps. Some we see, others not so much. Even sometimes as simple as communication and connections between facilities would have been a life-saving possibilities. This is a system originally created to oppress. Look at the DSM-5. Even the definition of opioid use disorder is a stigma embedded in itself, in its pages, omitting some of the inner struggles of the disorder. Casey became the stigma written on a paper, making her feel empty as she drowned in her own invisibility. She felt as she might as well just disappear. Casey's story is not uncommon, as we heard about Eliza, Mackie, and family. Also, were about in their 20s, facing many challenges, most likely stemming from the stigma that their youth likes to party. For us minorities, the challenge take is a different story. Sometimes as simple as finding a PCP who will listen, finding a therapist who can truly connect, feels like spotting a unicorn. Trust me, I know, as it's part of my intersectionality. I too have PTSD, anxiety, and ADHD. Yes, I see psychiatry, but the barriers to getting my medication become monthly with a 3-day scavenger hunt. And even though I'm surrounded by people in this very system, I sit and still wait for 5 years for therapy. Just like Casey, I am potentially one support away from ending up in reality. I'm not here to blame anybody. I'm here to help. It's not about me, it's about we. We all see bits and pieces of these issues. For example, as I sat here in the audience yesterday, I heard everyone speak about MOUD. I heard nothing in the case studies regarding the human background, the inner child within the adults on MOUD. Did you know that even kids in elementaries are using opioids or some substance? I know that for a fact. I don't need to study. Those kids don't feel that they have anywhere to go. If they speak, 51A court involvements, and some may even be deported. Whenever changes are made, there are always the perception that things will be better, but there needs to be a balance. As humans, we always tip one way or the other. There will always be gray areas, but with communication, we can build a stronger foundation. Eliminating departments of one, lowering caseloads, taking care of healthcare workers, owns mental health. Addressing our own internal biases and revamping education are often not addressed because not one of us can see the whole picture, nor one of these issues individually. Let's all band together, not in competition, but in collaboration. Savannah will grow up without her mommy, but you might like to know that we found a way to send her pictures to mommy in heaven. We got her balloons. She thought she decorated, attached her picture to them, and sent them up to mommy. Not very eco-friendly, but Savannah was happy. Oh, and as far as my introduction, my name is Paloma, And throughout history, my name stood for grace and serenity. It stood for dove, a symbol of peace and love. Thank you for allowing me to share Casey's story.
So you can see the importance of what each of you do. And uh, you have access to the patients, and the patients are coming to you, and they know what number to call, and they know to come and visit you. And for every one of those patients, there are 9 more patients, 90% of people who can't find treatment, like our kids and our family members. And we're hopeful. Well, I'm hopeful, and I bet you are too, that somehow you'll collaborate with primary care physicians, with mental health care physicians and providers to expand what you do to more people, so that Eliza and Casey and Joanne's family and Mackie have an opportunity for help, and it may be your children who are next. So with that, let me invite questions.
Michael Medlock, addiction medicine, north of Boston. I want to include the families because I know that they are important, but I have legal obligations to keep my communications private unless they give me consent. And I want them to know that they are my patient and not their family. You know, the family is secondary. They're my patient. I want to keep them front and center. So can you offer some suggestions on how you strike that balance and how you get the patient to consent for their involvement? How do you get the patient to consent for you to be involved and to be supportive?
For me, I asked Mackie, anything I can do, buddy? I said, we're at the doctor's office. I'll come in with you. And he said, no, he just needs to check that. This was a different kind of provider, and he doesn't want to talk to you. And but I think that was an outlier provider. And I think any one of you, if your patient said, can I bring my dad in? Can I bring my sister? The answer would have been yes. What do you think?
Oftentimes we have support groups across the state. And many times people's sons or daughters will come as guest speakers. And they say they were so happy when their parents started getting education and support around substance use disorder. So what my suggestion would be is to talk to your patient and say, you know, your family really doesn't understand your chronic illness. And they need to be educated around your illness. Because a lot of times in the very beginning, people don't understand that it's an illness. They think they can just stop. So I think education is key. You have something to say?
Yeah, I'd like to kind of jump on that too. I think, you know, it's really easy to look back 5 years and what would I have done differently, right? But I think at the point of diagnosis, the point of the first clinic, you know, if I had been able to have a conversation with the provider and say, okay, you can't share with me with Eliza's records. Okay, let's the 3 of us sit in a room and let's cut through all this bureaucratic crap and get to the point where, you know what, this is a dangerous freaking disease. This is going to kill your daughter, potentially. And I needed that wake-up call. I need that baseline. I need to say to Eliza, I'm really sorry. I can't trust what you're saying because of the addiction that you're kind of experiencing that's wrapped around you. But I want you to know that I'm here for you and I'm going to do anything for you, and have this level of trust and this baseline of compassion to build off of. And I understand the FERPA laws and the BURPA laws, and good Lord, there'll be some other QURPA laws that we have to jump through. But at the end of the day, these are our kids, our sons and daughters that are hanging in the balance.
I can add something. I'm also on the board of Mass Families for Change, and we deal with disabilities. If we look at it as a disability, in which I know there's laws and there's certain things you can't do, there's ways out there that things are being done. But to really answer you for what you can do tomorrow or Monday or Tuesday when you see somebody, you don't have to share your patient's information with anybody, but you can provide, oh, here's some information for your family if they're interested. Or even having somebody that works with you as a liaison, that's not a law that's being broken.
Mhm.
You're seeing the patient, that person reaches out to the family. That's a simple, no barrier, not a lot of barriers. That's what I would suggest.
Very helpful. Thank you.
There's one thing I'd like to add, and that's about Narcan, nasal naloxone, and we are a distributor, and we're a pilot for the Department of Public Health, so it's very important for a
Yeah.
family to know about overdose education and prevention and how to revive somebody with Narcan.
And I wanted to start off by thanking you all for your generosity of spirit and your courage. I will try to ask my question without getting choked up myself, which isn't easy to do. When I went into medical school, I thought I was going to be a cardiovascular surgeon. And it was after losing two of my own cousins to a combination of mental health and substance use that I completely changed my career and became a psychiatrist and addiction psychiatrist. And at the time, I found myself very similar to where you guys were at, right? I was the doctor in the family, and my family came to me asking me, well, what could we have done differently? What do we do now? And I was just a kid, really, at the time. I was finishing med school and I was the grieving cousin, and I didn't have any answers. But I'm a tough Colombian, and that's Colombia with two O's, not an O and a U. It's in the sportswear. And I'm a Taurus, and I sure as heck wanted to do everything that I could, to help my family and help other families. And I've been very privileged throughout the years to have nothing but the greatest of mentors and teachers and colleagues in the field. David Gasfriend was my program director, and he's here. And many, Dr. Armstrong, Dr. Keo, Dr. Poti. I mean, again, I feel so honored and privileged to be in the presence of all of you here today, really doing this work. The question that I really have, which has sort of puzzled me throughout the years, is, and again, and thank you for allowing me to speak, because every time I mention John Paul and Andres, it all comes back. Is a psychiatrist, we can send our patients to the ED, when they're suicidal and homicidal, and even sometimes then when we're trying to advocate to have them admitted inpatient because of their risk of, harm to self or harm to others. Even in those cases, we have to try to, make a case for, but at least, we have that pink paper and that section 12. And, sometimes we're successful getting them inpatient. Other times, unfortunately, we're not. Yet for patients with substance use disorders who have their prefrontal cortex hijacked, right, who have just had an overdose and have been Narcaned, who come to the ED after being in a motor vehicle accident, or, whatever the chief complaint that brings them there is, we don't have a way of, sort of, in that moment, sort of, sectioning or, against, in quotes, against their will or against the addictions wanting to live inside of them rent free. And for me, the, risk of harming self and harming others goes beyond suicide and homicide. So I'd like that to, be something that we think about. And sorry for the long Colombianishness that I get into, and thank you.
That's
Thank
okay.
you.
We did it too.
Thank you. And I was just talking about that the other day about harm to others and themselves. How can you say that somebody that came in with an overdose is not a harm to themselves or others? Of course they are. Why doesn't it fall in that category? So I agree with that.
I'm a little too short for this.
It's okay, I went through it already. You're gonna do fine.
I'm Marie. I'm a fellow at Boston Children's. So I just have more of a comment than a question while we're talking about involving families. I had a patient about a month ago, 18 years old. She overdosed Sunday. We were able to do her first evaluation by Tuesday, and we're planning to do a Suboxone induction Friday. She didn't show for her induction. We couldn't get a hold of her. I connected with her PCP. Her PCP is like, I can't get a hold of her. And eventually we were at a point where we're so worried about this girl that we were contemplating doing a welfare check at that point. So we had to make a decision of protect confidentiality. She does not want mom or dad involved at all, or her life is in danger. So eventually we made a decision to reach out to mom, and in order to protect her confidentiality, we didn't give details. We just said, we are incredibly worried about your daughter. She is at such risk of self-harm right now, whether intentional or unintentional. And it ended up working. Mom was able to track down her daughter. Her daughter wasn't living with her. She was living with her stepfather. It's a weird dynamic. But she was able to track her down, and daughter ended up opening up to mom about her use. So we were able to involve family and make sure she was safe without breaking HIPAA. So it was a
great.
decision we made. I just wanted to share that.
Thank you.
Great decision.
I'll be quick.
Yeah, I wasn't looking at him, so I definitely messed
Amy
up.
Thomas, I'm a nurse practitioner. I can relate with everybody. 20 years, and I didn't know anything about addiction. And the response we got from the pediatrician was, you need to be a better parent.
Mhm.
And I just want to say, thank you to Joanne. We did a Al-Anon, Nar-Anon, Learn to Cope really helped us. My kids started on methadone. I was horrified. And now, everybody has their own recovery. And it depends on the patient, but I tend sometimes to share, not too much, but I'm not in your shoes, but I can understand because I live along with my kids. And again, the message here is communication, including the family. Have your parents ever gone to, any of these support groups? And just, we've said it so much. We have to care about the person because they're somebody's family member. And even I've gone to many AA meetings to understand that side of it as well. It's not an easy path, but thank God we live in Mass and we have so many supports here and we're preaching to the choir. But I think I like to lead as a role model. You hear people with opinions and a stigma, and you just try to explain it so that they understand. Thank you so much.
Thank you.
I'm Gentine. I'm a psych nurse practitioner at Lynn Community Health and at the Mass General Hope Clinic. This is probably not a can of worms to open up when we have about 2 minutes left, but have any of you as family members had experience with the Section 35 system? And what do you think should happen with that system?
I've had experience with Section 35 years ago when my son was overdosing on the couch. And I didn't know what to do, what was going on. And I reached out to somebody, Jack Leary, years ago. And he told me about that process. I was scared to death to do it, and I did do it. My son today is in 16 years recovery. And he does say that if I had not done that, he wouldn't be here. However, it's changed a lot. I think it needs to be in a medical setting, not in a jail. MATSI, Men's Addiction Treatment Center, and WATSI, Women's Addiction Treatment Center, in New Bedford and Brockton were much better than Bridgewater, where my son went years ago, which was across the street from a jail. However, at that time in his life and in mine, I knew in my heart that I was going to be buying a coffin and a suit for him to wear in it if I didn't do that, because I had tried everything else. And I had 2 younger kids in the home. He was overdosing on my couch, which I didn't even realize was overdosed. And I did go in front of a judge and I begged the judge to help me because it was back in the days where it was like, and this was back in like 2003, 2004. He had been in detox and then get released, come home, relapse, detox, release, come home, relapse. And if I didn't have $70,000 to send him to a private treatment center, we were selling assets to try to afford treatment. And meanwhile, he was still overdosing, and I did finally use that process. We don't recommend it to people, but we do say it is a last resort. Was it always used as a last resort? No. Did it get overused? Yes. Can it be traumatic? Absolutely. But how many accidents was he in? We had one woman, her son, she had gone for a Section 35 and was denied, and he robbed a Walgreens that night and was shot and killed by the police. So he died anyway. So I don't demonize Section 35. I stay right in the middle because there are times when somebody is in such danger that they're going to die or someone else is going to die because they can't function. Then I think it's necessary. Section 12 can be really tough because it's 72 hours and they get let right back out. And a lot of times relapse, or I don't know, it's just there is no answers for any of this, but I don't demonize Section 35 because I have seen it save people, but I've also seen it used, overused, and, not been the best option too. So I guess I don't have a solid answer, but I do have a lot of experience.
And I know we only have we have 5 minutes left. Well, I'm thinking we're over 5 minutes. I would say that I don't know much about Section 35. I know that Casey just passed away this year, and her mother tried to Section 35 her, but because it was DCF and all these other things, it got really complicated, and she never made it to her on time. What I will say is that going back to what I read is there's no one answer for all of it. We can't continue to generalize. We have to find a balance. It might work for one person, but not another. And it's not the best answer, but it is what it is.
I think there are more humane and more effective options now. I'm not in
Yeah.
favor of it. And that's the short answer. I think there are better options now.
Give you my quick short answer. We did try to section Eliza at one point and argued with the judge, and I'm a systems guy. I had a bag full of evidence. I was like, this is the trouble. She's heading down this road. They didn't grant that. Right. So that kind of drove a wedge between us more than anything. But the other thing I'll say to you is that let's think about an alternative to that, right? Let's think about long-term treatment
Yeah.
availability. Hey, there's a novel idea.
Prevention.
Let's make a place where they can go and be safe and get help, not be incarcerated.
Yep.
And stigmatized further.
Let's talk to middle school, elementary schoolers, and let's change the education. So before they even get there.
I think we can squeeze in one more question.
Thank you. Hi, I'm Connie Flynn. I'm a nurse practitioner. I am the lead for the substance use disorder team at Berkshire Medical Center, way on the other side of the state, as far west as you can get. I also am on the faculty at UMass Amherst. And I think as I listen, and I appreciate your stories. I mean, I feel I have 4 children myself, luckily, with a substance use disorder, because, but I see it so challenging for families, and I'm really, really sorry for all that you've been through. That being said, in my experience, I feel like the biggest piece we're missing is a lot of education. Being an educator at UMass Amherst, we're actually starting an addiction certificate program for nurses, nursing students, whatever. It's going to be like a 10-credit course that we're working on. Since I've been at UMass, we've done a lot more education to nurses and nurse practitioners on substance use disorders. And I feel like the advanced practice people are going to be the ones that are going to make a big impact on treating substance use disorders. And I guess my comment is I also work, on my substance team. So we have medical residents that come with us. And I know that several years ago, the curriculum in medical school was to put addiction education into the curriculum. And I can say we work with the new graduates who tell us over and over again, they don't know anything about addiction. So we're in this building with the Mass Medical Society. So, I mean, no, I'm just, no,
Just put a plug right in.
about this. I mean, I'll have like, not the chief of medicine, he's very into this, but I've had people in the hierarchy within the hospital system that I'll mention the word Suboxone and it's like I've said the worst word ever, and they'll say, I don't want anything to do with that stuff and everything. So and so the way that people are treated by the medical people, I mean, so you guys are in this room are great because you all get it, but how can we get your peers on board with this? I see that as making a big difference, that if, the primary care people who don't, like they said, I don't treat that. I run out of the room understanding that. That's really what we have to do. That would be a big part of it. It's just getting more people involved. I know we're running out of time, but anyways.
Well, thank you for sharing that. And as the new leadership takes on a role at MASAM, I can promise you we'll work on that.
Yeah, and I'd love to help.